triangle of auscultation. The upper trapezius, the border of the scapula, and the lats. There's a little area in here without bone, but there's only intercostal muscles. That's very good for listening to the lungs. So it's called the triangle of auscultation. I don't have one of these skeletons here, so I guess I'll have to get away without that. If I look at this, and I'll keep my shirt on and just let him do it, over here, there is a sternal angle. The manubrium meets the body. If we go out here, this is the second rib. If we go from the greater trochanter towards the belly button, 1/3 of the way towards the belly button, that's McBurney's point. Underneath McBurney's point is the appendix. If you press on the belly while he's sitting with his knees up, and then you take your hands off quickly and there's pain over McBurney's point, suggestive of appendicitis. This here is the cubital fossa. It has, aside from the antecubital vein or the median cubital vein that we use to draw blood, we have to stay almost parallel to the skin, because if you go deep in there, you run the risk of hitting the biceps tendon, the brachial artery. Medial to the biceps tendon is the brachial artery, and the median nerve. Over here is where you'll get your radial pulse. Here's where you'll get your ulnar pulse. We have the palmaris longus, which is the one, it's the most prominent tendon, but on like 10% of the people, they don't even have that. To the right or towards the thumb side will be the flexor carpi radialis. And on the ulnar side is the flexor carpi ulnaris. Those are the three main bulges we see here. A little deep is that flexor digitorum. This is the femoral triangle with the inguinal ligament, the adductor magnus, and the sartorius muscle. Here's where we'll get the femoral pulse. Popliteal region behind the knee, that's the popliteal fossa. That's where we can get the popliteal pulse. Behind the medial malleolus, we'll get the posterior tibial pulse. You can look at the other things I said, but those, I guess, were the main things. When it comes, I'm not going to take out slides again, but where is the endocrine system? When it comes to the endocrine system, if you see cells that have this colloid solution in the center, this is the thyroid gland. It has a whole bunch of these follicles. The cells that surround them are called follicular cells. If I point to a cell like this one that's not surrounding a follicle, that's a parafollicular cell. Parafollicular cells produce calcitonin, lowers calcium levels in the blood. Follicular cells produce T3 and T4. They're stimulated by TSH. If I'm giving you the pituitary, if I'm giving you the pituitary gland, I'm not just gonna show the anterior. I'm gonna show these two side by side. And if you see the strings going through this, and you see a very glandular tissue on the other side, didn't look blue like that, but it looked like it was very cellular. This one just had dots and strings. This is the neurological neurohypophysis or posterior pituitary. Two hormones are released from here, ADH and oxytocin. The adenohypophysis or anterior pituitary will make all the other pituitary hormones. ACTH, FSH, LH, TSH, prolactin, and growth hormone, and MSH. The parathyroid hormone, I won't show it like this, it doesn't look like anything. But if you see the thyroid gland, and it looks like there's another gland behind it with all kinds of cells, that's the parathyroid gland. This is where parathyroid hormone is made by chief cells. If we see these cells around circling this area, and these are called acinar cells, there's ducts in the center. It's easier to see on a slide, but you got this little island in here, this is a pancreatic islet. So if I say what region of the cell is this, it would be a pancreatic islet, sometimes called the Isles of Langerhans. But pancreatic islet is probably easier for you to say. And if I ask a question, what do beta cells make? It's insulin, and you know I'm probably pointing to a pancreatic islet. What does alpha cells make? Glucagon. Which cells make insulin? Beta cells. Which cells make glucagon will be alpha cells. So if I'm asking that, I'm probably pointing to a pancreatic islet. I don't like the slides on this, so I would use the picture. I don't even think I'll use the picture this time. We have enough things because we did that virtual lab. The virtual lab. We did another 2 virtual labs actually. So in the virtual lab, the first experiment was looking at the effects of thyroid hormone on the BMR, or basal metabolic rate. We determined that by looking at the amount of oxygen that's consumed each minute based on the weight of the animal per kilogram body weight. So we had wrong experiment. So we had 3 different rats. Here it is. We had 3 different rats. Probably not going to ask you that this is called a manometer that's measuring oxygen. But the first rat was the control rat. It's normal. The second rat, TX, thyroidectomy, the thyroid was removed. The third rat, hypophysectomy, HYPOX, the hypophysis was removed. Hypophysis is another word for pituitary. So now you know that the 2 rats without thyroid gland or without the pituitary, because without the pituitary you have no TSH. These 2 rats are going to have a slow basal metabolic rate. If you inject any of these rats with thyroxine, you're going to increase their BMR. So these 2 rats will probably come up to normal. There won't be any goiter anywhere. You're just giving thyroxine. Now, if you give TSH to a normal rat, he might start producing too much T3 and T4. And if you palpate him, he'll probably show a goiter because he's getting too much stimulation. If you give TSH to a rat that has no thyroid gland, that's going to have no effect on its basal metabolic rate because there's no thyroid gland there to stimulate. If its pituitary was removed and you give TSH, you'll raise the basal metabolic rate because he still has a thyroid gland. He just can't create his own TSH. So if you give him TSH, he'll be fine. This polythyrouracil blocks the iodine from binding in the thyroid gland. Won't affect these two rats. They have a low basal metabolic rate. It will create a problem with this rat. He won't be able to make T3 and T4, and his body will probably produce a lot of TSH, so he'll have a goiter. Animals or people that have iodine deficiency, even though they're hypothyroid, they also show a goiter because they keep getting stimulated with TSH. So that's the thyroid experiment. With the glucose experiment, we're gonna come up with a standard curve. Do they show us a picture of it? Well, I have a picture of it. Standard curve. And based on the line that makes the standard curve, if someone gives you an optical density, you can move over to the standard curve, go down, and figure out how much glucose is in that unknown sample. So the standard curve, we have known amounts of glucose. We look at the optical density. We draw a line that represents that. Now you have an unknown sample. We determine the optical density. We use the standard line to determine how much glucose is in there. So we can do that on the test. With this experiment, with the adrenal cortex, whether I give it to you now or I give it to you I gave it to you lab test already. I mean the lecture test. If someone has high cortisol levels, he has Cushing's disease. He's hypercorticolism. If the cortisol levels are high and the ACTH is low, there's a problem with the adrenal gland. He's not being stimulated to produce more cortisol, but he is. That's a primary Cushing's. If, on the other hand, the cortisol is high and you take ACTH and that's high, the problem isn't with the adrenal glands. It's probably the pituitary or hypothalamus. That's secondary. If it's low and we see that the ACTH is high, then it shouldn't be low unless there's something wrong with the adrenal gland. So that's adrenal primary Addison's, or primarily a problem with the adrenal gland. If it's low and we see ACTH is low, the problem is probably not with the adrenal gland, it's with the pituitary or the hypothalamus not providing enough ACTH. So that's a secondary problem. So that's what I would want you to know from the virtual lab. While I got virtual lab, we'll look at the virtual lab we did on the heart. So from the heart experiment, we learned that the heart muscle has a longer refractory period than skeletal muscle. Because of that longer refractory period, you can't really tetanize it to get a stronger contraction. The best you can do is after a contraction, you can get another quick contraction. That's called extrasystole. And extrasystole is usually followed by a compensatory pause. We don't see it in this diagram, but we did it on ours, so I might have a picture of that. Do they show extrasystole here? I don't think so.
That was that like a big gap.
Big gap was the compensatory pause. But when the two of them are close together, that's extrasystole. Because we stimulated it very fast, just after the refractory period. No, I don't see it. So there are things that made us speed up the heart rate, chronotropes, speed up the heart rate. We can heat it up. We can treat it with some sympathetic like drug or hormone like epinephrine. Norepinephrine is a neurotransmitter that will speed up the heart. Epinephrine will speed up the heart. Thyroid hormone will speed up the heart. Calcium will speed up the heart. Parasympathetics will slow down the heart. So there are 3 drugs here, or I care about 3 of the 4. Epinephrine speeds up the heart. Also causes a stronger contraction called an inotrope, but this is looking at heart rate. Epinephrine speeds up the heart. Pilocarpine mimics the vagus nerve. It's parasympathetic. It will slow up the heart. Atropine will block parasympathetics. So it really acts like epinephrine. It speeds up the heart. Typically, we're under vagal stimulation and our heartbeat is slowed by the vagus nerve, releasing acetylcholine. Atropine blocks the acetylcholine receptor, so it will speed up the heart. Epinephrine speeds up the heart. Calcium will speed up the heart. Pilocarpine slows the heart. It acts like the vagus nerve. And much of the heart we already did today when I discussed all that stuff. But if you're looking at blood vessels, there are 3 branches, and I have the heart models that come off the aorta. The first one goes to the right side, right here. That's called the brachiocephalic. It splits into 2. I don't see it splitting into 2 in any of our models, maybe the board, but I don't think that's a good view, so I probably won't give you that. But you wind up with the right common carotid and the right subclavian. See how the subclavian goes underneath the clavicle? The next branch to come off the aorta is the left common carotid, and then comes the left subclavian. So from the subclavian, you go into the axillary region, your armpit, as the axillary artery. And it gives off a circumflex that goes around the deltoid. It then continues down the arm, that we'll see on the arm model, as the brachial artery. This is the one we squeeze when we take blood pressure. And the brachial artery will split into a branch that goes near the thumb, the radial artery, and a branch that goes near the pinky, the ulnar artery. From there, we have the aorta going down the thoracic as the thoracic aorta. At the bottom of the thoracic cavity, will be the diaphragm. And if you take that large model, you'll see where the abdominal aorta punctures the diaphragm. There are these three branches that come off there. There's a branch going to the liver, the hepatic arteriole, one going to the spleen, the splenic, the stomach, the pancreas. These branches are all referred to as the celiac trunk. So if I point to this first large trunk with all of these arteries coming off, that's the celiac trunk. Underneath is a large artery, that's the superior mesenteric. Lower down is the inferior mesenteric. Just below the superior mesenteric to the right and left are the large renal arteries. One of the trunk models shows a suprarenal artery going to the adrenal gland. And notice how they're yellow, because the cortex is producing all of the cortical hormones made of cholesterol. The mineralocorticoid aldosterone, glucocorticoid cortisol, and androgen, the DHA, dihydroepiandrosterone, like testosterone. In the center of the adrenal gland is the medulla. That's where we make epinephrine. That's not fat soluble. So at about the fourth lumbar vertebrae, near where your belly button is, the abdominal aorta bifurcates. One branch goes to the right side, one goes to the left. This is the common iliac. Just above here is where we see abdominal aortas. Abdominal aortic aneurysms. Because the bifurcation causes turbulence, and sometimes we rip the endothelial lining and you'll get a bulge here. So, not such a good picture over here. This one's better. So the common iliac splits into a small branch called the internal iliac artery, going to the bladder and the gonads. And then the larger, thicker branch proceeds into the leg. This is called the external iliac. When it goes underneath the inguinal ligament, it's now here and becomes the femoral artery. Out to the side is the lateral femoral cutaneous artery. And the circumflex circles the hip. So the femoral artery proceeds and goes down the back of the knee, which we see on one of those models, as the popliteal artery. So up here it's femoral, behind the knee it's popliteal. When it comes behind the knee and proceeds behind the leg, it's called the posterior tibial. The one that goes to the front of the leg will be called the anterior tibialis. And from the anterior tibialis, we then reach the dorsal pedal. And that's pretty much the arteries that we covered. Today we talked about the parts of the EKG, the P-wave QRS complex and T-wave. We mentioned that you need to be able to identify these part of the electrical conduction system. You should know what pulse pressure is and what is the systolic pressure from the diastolic pressure.
What we learned today is gonna be on the exam?
What?
What we learned today is gonna be on the exam tomorrow?
Yes, what we did today.
The EKG and the blood pressure?
EKG, but just know that graph, so it's not a lot.
What about blood pressure?
And blood pressure, you know the top numbers, the systolic, the lower numbers, the diastolic, you take the difference between the two, you have your pulse pressure. There's something called an apical pressure, where a nurse can auscultate and listen to the heartbeat figure out the heart rate by auscultating the heart. Another nurse can take the beats per minute by feeling it down here. In older people, sometimes the beating of the heart isn't strong enough to cause a pulse out here. It's known as an apical deficit. I thought that would be really unusual, but somebody in my class that was a nurse said, no, we see that a lot in elderly people, that we take a pulse at the wrist, and it's different from if you're listening to the heart. So know the coronary arteries. Here is the left coronary artery, the circumflex, and the anterior interventricular. So the anterior interventricular feeds the left and right ventricles, and the circumflex feeds the left atrium and left ventricle. The right coronary artery serves the right atrium and right ventricle, and the marginal branch serves the right ventricle. From behind, we have the posterior interventricular coming off that right coronary artery, and it serves the right and left ventricles posteriorly. The coronary sulcus is behind. So I'm not reaching up and grabbing the models, but you can see them on the models. There are the two of the pulmonary veins coming into the left atrium with oxygenated blood. The ligamentum arteriosum is here, and the fossa ovale is here. This is the pulmonary trunk. If I use a real heart and I say it's an anterior view, if it's in the front, it's the pulmonary artery, and it's usually taking a flat turn like this. Behind it will be the aorta. Superior and inferior vena cava you can't see on the real dissection, but you can see it in the model. On the real heart, the thicker muscles are within the left ventricle. Right ventricle will be skinnier. So if I have the right ventricle and I point to the cusp or the tendons that's separated from the atrium, and I say, what valve is this? Tricuspid. Over here, it's bicuspid or mitral. What are these tendons? They're called chordae tendineae. What is the muscle attached to here? They're papillary muscles. This is the pulmonary semilunar valve. I see it well on our heart model. And over here, I can see the aortic semilunar valve. Know where to auscultate the sounds? Oh, from another picture we had where we listened to different parts of the heart. I don't know where it was that we listened to them. Oh, 33. So know the regions, what each region is used for. Aortic semilunar, pulmonary semilunar, mitral or bicuspid, tricuspid is listened to here. I will not put this on there, but it's a good thing to look at when you're studying for the lecture. Because if you understand this, you understand most everything. Right? So that should do for